Tracey Shannon is a doctor of physical therapy. She has worked at Children's Hospital in Colorado for 7.5 years, 5 of those years as part of the chronic pain team. Part of her area of interest is the focus on therapeutic neuroscience, education, and graded motor imaging for the treatment of CRPS and chronic pain. I had posted on RSDSA's Facebook page a request for a physical or occupational therapist familiar with graded motor imaging and mirror box therapy in Colorado. And I got a referral for a fellow named Bill Parr. And I got in touch with him at Children's Hospital. He says, "You don't want me, you want Tracey." So we have her today. And so please give a warm welcome for Dr. Shannon. Thank you.
Thank you, Jim, for inviting me to speak about something I'm incredibly passionate about. It's an honor to be here today to provide some education on my treatment strategies and what I hope that other physical therapists can adapt and adopt to, because there is evidence to support some of this. I'm a physical therapist, not a public speaker. First and foremost, I have no financial relationships with any of the groups that I'm presenting about today. I just love the research and find it very helpful in how I help my patients. By the end of this presentation, I hope that you guys will be able to understand the importance of pain education with patients with chronic pain, be able to describe a typical pain response, differentiate acute from chronic pain, and acknowledge that complex regional pain syndrome is a central nervous system impairment, and then list the 3 phases of the graded motor imagery technique. So, just a raise of hands. I know there's red and blue name tags. How many are patients with CRPS? Okay. And then family or caregivers? Wow, thank you guys all for being here. That's fantastic. And how many of you just love to come on a Sunday morning and learn about pain? I know I enjoy talking about pain, and I think most of my friends and family and all my patients think I'm crazy because I absolutely love talking about it. But without any further delay, let's get started. So for the next about 45 minutes, I'm going to provide education to you. Therefore, I felt it very important to include some research speaking to the importance of patient education. A research study was done, and it included 8 little studies about the importance of patient education. Evaluating the effect of providing education with patients with chronic musculoskeletal pain. The education was similar to what I'm going to be going over today, and it was given by physical therapists. The most common frequency was once a week for 30 minutes in a one-on-one session. The average time equaled about 2.5 to 4 hours, and the results support pain education decreases pain ratings, perceived disability, pain catastrophization, and increases physical performance. So the current best evidence out there supports the use of pain education in conjunction with physical therapy helps patients. With that being said, what is pain? I had a patient once tell me, it's like asking me to define the color blue. Okay. So go ahead, shout a couple answers. What is pain? Yeah. I think all of us can agree that it's horrible, painful, ridiculous, miserable. So I learned to rephrase my question. What is the purpose of pain? It's an alarm system. It's to protect us. It's a warning and alert. So pain can be an indication of tissue damage, whether it's pressure, ripping, tearing, piercing, burning, biomechanical dysfunction. So that's a physical therapist term of saying poor posture awareness or poor body mechanics. When you go to pick something up and you have poor body mechanics, you're going to overuse certain muscles and not use any, or really stretch your ligaments. Muscle imbalance. irritated tissue, wearing shoes that cause a blister or a sunburn, unhealed or poorly healed tissues, a fracture that didn't heal correctly, a skin sore that develops an infection. What would you say if I told you you don't have a single pain nerve in your body? It's already controversial this morning, so. This is how I start my conversations with most of my patients. I educate them that they have 3 types of sensors that could be grouped in a painful category. These are mechanical, chemical, and temperature. If I put my hand on a hot stove, what would I do? I would remove my hand. If I was walking along and I stepped on a nail, what would you do? Or what would I do? I'd pull my foot back. And then chemical, I like to relate because my patients can relate. A flu shot, you get a flu shot. If you don't move your arm, it becomes a little bit sore. So there's chemicals injected and your body's trying to figure out what they are. So these sensors pick up change in your body and they relay it up to your brain. It's in your brain that it's processed and integrated with memory, experiences, past experiences, cultural beliefs, social situations, everything, and pain is given as an output in order to protect yourself. So right now, each of you have sensors communicating to your brain that you have an increased pressure on your bottoms, because most of you are all sitting down. These sensors send the change of information up to your brain, and your brain processes that information and allows you to continue sitting because you're okay. You're not in threat and you're not in danger. However, if you continued sitting still without any weight shifts and for a very long period of time, that information of change would intensify, and your brain would eventually tell your body to move to prevent soreness or tissue damage. In this picture, kind of like we just talked about, if I put my hand on a hot surface, my sensors in my hand send information up up my spinal cord to my brain. The information, I wish I had a pointer. The information floods the dorsal root ganglion. That's just in your spinal cord. It's kind of like your mini brain. It allows information to go up if it's important, and if it's just a minor amount of information, it stays local. Your brain doesn't know about it. Your brain decides what action is needed when it receives information of change from your sensors and your nerves. Therefore, pain is constructed by your brain, not your body, as a way of alerting you to actual or potential tissue damage. Again, it's an alarm system. Even thoughts can set off the same alarms directly from within the brain without any input from the body. Many things play an important role in your experience: your social life, your cultural beliefs, your previous experiences, your expectations, your knowledge can all contribute to your ability of getting better. That's why I'm sure most of you know by now, pain is best treated from a multidisciplinary approach. Many people, physical therapist, a psychologist, psychiatrist, pain physician. Well, I already gave you a clue. Do you all know who Bethany Hamilton is? Yes. For those of you who don't know, she was the young lady who had her arm bitten off by a shark. And so if we go back to reconceptualizing pain, what is pain? The amount of pain you experience does not tell about the amount of tissue damage that you've sustained. In some of Bethany Hamilton's interviews, you'll hear her say, "I didn't have any pain." You'll hear her friend say, "She didn't even scream." She knew that in order to save her life, she had to swim to shore. So her brain prioritized saving her life in order for her to get back to shore. If we go back to this picture, and I was a professional pianist. I played the piano for a living. I paid my bills by playing the piano at recitals and concert halls. And I got let's say, a blister on my finger from a burn. Now I'm starting to worry about the precision of my movement on the piano. I'm worried about, is the audience going to accept me? Am I going to mess up? Am I going to lose my job? the thoughts go on and on and on. Whereas if a dancer sustained the same blister, she might not actually have the same amount of pain as I have, because it's not a threat to her. It's not as big of a threat to her as it is to me. I always reassure my patients that their pain is exactly what they say it is, when they say it is, however they say it is. Their pain is their experience. I'm just here to help. As Jim told you, I work at Children's Hospital on the chronic pain team. One thing I've found particularly interesting is how the word chronic is defined by my patients. Now, keep in mind, my patients are under the age of 22, and I hear them define chronic to mean horrible, incurable, really bad. Well, no one else knows what to do with me or what's wrong with me, so they sent me to you. It was at that point that I started to educate on what chronic actually means. And I'm trying to get them to change the name of our clinic. As illustrated so eloquently in the Explained Pain book, if you guys have not read this, this is an excellent resource. It is by David Butler and Larimore Mosley. It's an excellent, excellent resource. This graph shows that pain should diminish as tissues heal. Acute pain is typically considered less than 1 month. Ideally, after injured tissues have healed, pain levels decrease, and eventually pain is no longer an issue. However, as pain continues past the appropriate amount of time for tissue healing, the pain can be more associated with the nervous system, hypersensitivity. Chronic pain is greater than 3 months. Patients with chronic pain often state symptoms to me of persisting pain. The pain is spreading, pain is worsening, movement hurts, pain is unpredictable. That's because impulses or nerves carrying that information of change continuously arrives at the spinal cord. Therefore, the number of synapses and sensitivity-enhancing chemicals increases. There are changes. My point to this is there are changes in your body that happen when you have a continuous signal coming from the affected limb. Simply put, if your brain continuously receives information of change, your nervous system will eventually become more sensitive to that particular area as a way to protect yourself. This is my favorite saying. I get this all the time from my patients, that a doctor said it's all in my head. Well, I actually really love this because quite literally, yes, yes it is, because your brain constructs pain. So if you didn't have a brain, you wouldn't have pain. I'd like to shift our focus to one particular diagnosis that you're all very well aware of. And I'd only like to briefly discuss, as it'll be later discussed in much more depth. Told you. Okay, complex regional pain syndrome. What is it? I really try to break the ice with my patients because really by the time they get to us, they have seen every discipline, every doctor, and they're just frustrated. So I try to be a little bit funny. I said, well, is CRPS contagious? Am I going to get it? I want to know what their understanding of this diagnosis is. So briefly, complex regional pain syndrome is a chronic pain condition, usually affecting an extremity after an injury. Clinically, patients present with allodynia, or disproportionate pain. Pain is regional in nature. There are findings of abnormal hair and nail growth, temperature changes, swelling, sweating, possibly range of motion and strength changes. Essentially, it's a disease of the central nervous system with peripheral manifestations. I know it looks like a slide with a bunch of big words, and I agree. So I'm going to try to explain it. As a physical therapist, I try to focus on the following impairments. Disruption of the sensory cortical processing really means to me that a pain response has become too sensitive. Disinhibition of the motor cortex is basically a loss of precision, which can disrupt movement commands, sensory function, and perception of body parts. Disrupted body schema. The idea of idea of smudging, which we'll later come back to. First, in order to understand smudging and the idea of the loss of precision of body parts, I want to talk and educate you a little bit about a part of the brain called the homunculus. It's Latin for little man. It sits right over your ear. Excuse me. And it's a map of the body. There's a sensory and a motor homunculus, which are in constant communication with each other. As you can see, the face and hand are enlarged. That's because we have lots of sensors, many, many more sensors in our face and in our hand than we do the rest of our body, in order to smell, taste, and be able to differentiate a quarter from a penny. The little fine motors in our mouth in order to talk, and the fine motors in our fingers in order to function, in order to write, in order to pick up a cup. Lots of sensors come from our hand and our face. So going back to our concept of smudging, this cartoon illustration depicts the concept of smudging in which areas of the brain that normally represent different body parts start to overlap. As you see on the right, the hand is smudged. It no longer has the definition of the fingers. That's when we get that constant complaint of, it hurts all over, because our bodies start to lose the recognition of what is that particular body part. The brain actually starts losing the ability, and there's actually cortical or brain changes that we'll later talk about. Our goal is to fix this. Our goal is to improve your brain's ability to identify the body parts. How many of you have a background in research or statistics? I do not either, so bear with me. I tried to bring it down to the way I understand it. To illustrate the presence of the brain changes, as we just saw in the cartoon, I included this study which aimed to find a relationship between the changes in the brain and improvement of clinical symptoms, particularly pain. They took 10 patients, 7 women, 3 men, with an average age of 58 and a half years old. They took them 9 weeks after symptoms first occurred in the upper extremity, and then they did a follow-up at 1 year. The participants received 20 puffs of air of varying intensities to the first and fifth digit of the hand, and also to their lower lip, while a device mapped the area of representation in the brain. Magnetoencephalography, something like that. This is just the device that actually shows where the puffs of air were represented in their brain. As you can see, the distance was calculated and compared to the unaffected side. Measurements were taken at the initial and at the 1 year follow-up. If you look at the first one on A, I guess you can't really see the measurements, I'm sorry about that. The first on the left side of the brain is 0.8 centimeters. And at the 1 year treatment, the distance improved to 1.45 centimeters, which was more comparable to the unaffected side. Does that make sense? No. Okay. I wish I had a pointer because you would be able to see it a little bit better. On the top picture on the left, it says 0.8 centimeters. So they took the distance of the air puffs on the first finger and the fifth finger, and they calculated the distance, and it was 0.8 centimeters. On the unaffected side, it was 1.42 centimeters. That's the distance of that homunculus, of where your first and fifth finger is represented in your brain. After treatment, the treatment that we'll talk about today, it neutralized. That, I guess, is the take-home message. The treatment actually helped your brain, their brains, recognize and start recognizing and being able to draw the distinct difference between the first digit and the fifth digit. The big take-home message, evidence shows that patients with CRPS have cortical changes in their brain on the affected side. Cortical representations of the body, that homunculus, your body, the map of the body, some areas have appeared shrunken, and they actually start to overlap. But after treatment, reduction in pain score actually correlated with the changes back to neutralize in the brain. I'll explain later. This is another one. Someone told me this once, and I keep bringing it forward because I think it resonates with me, and I hope it resonates with some of you. If persistent pain, so chronic pain, is an exaggerated defensive response as a consequence of an exaggerated perception of threat, then treatment is focused on downregulation of the central nervous system. In other words, decreasing all inputs that activate the defensive response. Homuncular, again, the map of the body, the cortical changes. We want to nourish that part. We want that to become neutralized back to the other side. We want to do this by treating under the radar. We want to treat you by not evoking a pain response. Peripheral neural modulation. Hopefully, by this point, you've seen a physical therapist and you've gone over some nerve glides, helping your nerves regain the flexibility and the elasticity to glide through some tissue. Pacing and graded exposure. This is patient-directed. Progressive exposure that considers anxiety, fears, and sense of safety. I want to focus on homuncular nourishment because it's unique and a specialized treatment that hopefully will help guide you in your journey. So what is it? It's just a sequential process of rehab where the therapeutic targets are really the nerves in your brain. We want to activate your brain without making you have pain. We do this by a technique called graded motor imagery. There's 3 phases. Laterality reconstruction, motor imagery, and mirror therapy. Laterality reconstruction. Patients with complex regional pain syndrome often have a difficult time differentiating and determining left from right. Laterality reconstruction helps to restore the brain's concept of left and right. The process activates the premotor cortex to avoid activating a pain response. So we're only poking at the part that's going to cause a pain response. The goal is to improve cortical representation in your body. It's to help you understand the difference between left and right and be able to recognize your left hand again, your right leg again. A patient with CRPS usually will present with a delayed response time in identifying the affected side. In my experience with children, they will also have a decreased accuracy on the affected side, which may represent an impairment with their ability to mentally move their limb to mimic the image. We'll go over this. So this is what it looks like, and this is where it was very important to me to let you all know I do not have a financial relationship with this program. I don't receive any profit. So we use an application called Recognize. It's with an S, not a Z, as it's an Australian-based technique. They got on this research a little bit earlier than we did. This app helps to calculate the accuracy and the speed for each patient. The program allows us to alter the number of images and the context in which the image is presented. The app may be purchased on Android or iPhone, and last I looked, it is about $8.99. When I first started this, it was 99 cents or free until the research started to support this technique. Then they caught on. There are multiple types of Recognize. There's one for the knee, hand, foot, neck, shoulder, and back. This technique has also been shown effective in other populations. Phantom limb pain. I'm sure a lot of you have heard the research about phantom limb pain and how it might be similar because, again, your brain is what is creating that pain. To go back to Recognize, the first stage of Recognize is called vanilla. It's just plain. You're going to see plain images of hands. I chose hands just to show to you guys today. You're going to see plain images, and you're going to have to identify what hand that is. and you'll be measured accuracy and speed. So a patient with CRPS of, let's say, the right hand or right extremity might see this image and think, well, there's no way that that can be my right hand because it doesn't cause me pain to look at that hand, so I'm going to guess left. So then they guess left. That's my experience with children. In adults, it's a little bit different. They'll see this, they'll think, okay, this is my right hand. No, it can't be my right hand, it's painful, so it's got to be my left. They try to move their left hand, it doesn't look like the image, so then they go back and they guess right. That slows down the time on the right side. These are just other images that you'll see in vanilla, just plain hands in a plain background, adding in a little bit of a movement to the shoulder. This is how I treat my patients. This has also been shown in the research. 5 times a day, this program is done. When you're first starting, it takes less than 5 minutes every day. The goal is to get greater than 90% accuracy in less than 2 seconds. When you do that, and it's consistent, consistency is a little bit all over the board. Some researchers say 1 day, some researchers say 1 week. In the Graded Motor Imagery Handbook, it says 1 week. I chose 3 days. As long as you're consistent for 3 days, I advance you. So increase the number of images to 50, and this will make sense if you get the app. You start, it defaults to 20 images. Once you are consistent with greater than 90% in less than 2 seconds, then you'll go up to 30 images until you achieve that same goal. Once you achieve that goal, you're going to switch to context. So it's the second option down. With context, it's just like it says. It's a hand in the context of something. This person is working. So there's different theories, and I want to explain both of them just in case you do decide that this might be an app for you. When you're working, you can actually, if you got hurt on the job, you can actually associate work with pain. So your score might be altered because your brain has to tease out, ooh, that was really painful. That screwdriver, his hands look dirty, his hands look like he's really been working, and I attribute that to pain, so I don't know what hand that is. So now your brain really has to focus past what the hand is actually doing and say which hand it is, left or right. Again, in context, once you achieve your goal of greater than 90% in less than 2 seconds, with 50 images, you go on to abstract. Abstract looks like this. This can often be perceived as very painful to someone because there's fire. A hand is near fire. That is painful. So we have to fight those thoughts again and just focus on which hand is this that I'm looking at. Like I said, it's sequential, so once you are able to better identify left and rights, then you move on to motor imagery. Motor imagery helps by exercising neurons in a graded way, slow progression of exposure. You're imagining yourself moving into different positions without any body movement. The goal is to stimulate the primary motor cortex without making a pain response happen. Once you're able to think and move without pain, we start the third phase. Some of my patients can't even imagine themselves moving because it causes pain. So then we look at other people. They watch me move. They watch other patients in the gym move. They imagine movements. They watch a movie and watch them move. They pay particular attention to their left hand, their right foot, whatever it is. Mirror therapy. I will be very honest. When I learned about this in PT school, I thought there's no way I would ever do that. That is hocus pocus. How could you look in a mirror and cure pain? However, the research to support mirror therapy is astounding. It is amazing, and it is what makes me so passionate about what I do. Mirror therapy provides an illusion to the brain that the affected limb is moving without pain. The phase activates the motor cortex. So now we're creeping into where the pain response actually happens. But it's on the unaffected side that's moving. So we're trying to trick your brain and move in a normal, pain-free way. I included two research studies, but I would rather talk a little bit and maybe even go over mirror therapy if you feel like that would be helpful. Other treatment strategies for complex regional pain syndrome include cognitive behavioral therapy. Many of you probably already know, again, that the research supports an integrated, multifaceted approach to chronic pain and chronic treatment. I am so thankful to work with the team I work with. My pain psychologist colleagues are amazing, and I'm so thankful for their help. They are the ones that really target cognitive behavioral therapy. So I'm just going to list them. So activity pacing, we of course address that in physical therapy as well. Attention diversion, cognitive restructuring. Instead of saying something hurts right away without even trying it, let's talk about it. Let's see what it could be fear. It could be your fears driving your pain. Goal setting. This is, again, something that we focus on in physical therapy. We start small and we build. Graded exposure, slowly adding back the activities that you were no longer able to do. Motivational enhancement therapy. I can only imagine how tough it is to make a change and to move forward and to push through some of it. So of course you need motivation, and of course you need a support system. And I hope that each of you has a team that you feel is a support. Maintenance strategies and problem-solving strategies. So I'll just summarize, and then I'll go over a little bit of mirror therapy. Neuroscience, so pain education is an integral part with rehab for patients with chronic pain. Your providers should be educating you on what pain is. You should be talking about pain. Complex regional pain syndrome is a central nervous system impairment with peripheral manifestations. So it starts in your nervous system, and it affects your limbs. It affects your hands, your feet, your legs, your back. Graded motor imagery, so the laterality reconstruction, motor imagery, and mirror therapy is an evidence-based treatment strategy for patients with CRPS. Thank you.